Hello everyone, we're talking about chronic kidney disease. Go back and watch Kidney Basics if you haven't, because that covers some terms we'll use here. And this will be mostly patient management of chronic kidney disease. So here are the objectives. Defining CKD and the staging criteria, describing the progression and high risk features, and identifying key management strategies. So 15% of US adults have CKD. That amounts to about 35 million people. Creatinine won't identify it until it starts to get pretty bad. Normal GFR is about 120, and it won't catch it until it's at least 90, if not closer to 60. Minorities are at higher risk to progress to end-stage renal disease, and that's just due to worse diabetes and hypertension in these groups. The biggest risk factors are hypertension and diabetes, and those are the big ones. So 80% of CKD is probably hypertension, diabetes. And then you get into primary kidney diseases like glomerulonephritis, polycystic kidney disease, lupus, some of these things. And CKD is associated with early death, heart disease, and strokes. So the pathophysiology starts with the loss of nephrons. And then when those nephrons realize that they're working with less of each other, they start hyperfiltering. So this process causes stress on the kidney. It's much like heart disease or heart failure, where once your EF drops, the heart remodels and gets bigger and tries to work harder, which in and of itself makes the disease worse. So it's similar in the kidney, and we'll talk about that. So staging CKD, this is how we think about it. So in very basic terms, you have normal kidney function up until about a GFR of 60, which is still losing half your kidney function. And then you're in this yellow range of kidney disease, where we're trying to prevent progression. And once you're in the red, we're starting to think about replacing your kidney function with dialysis. This gets a little closer look at the staging based on the glomerular filtration rate. So this is something primary care providers will order. They may do a 24-hour urine collect and really nail down where the GFR is. And this last slide really shows how big a deal proteinuria is. Loss of protein in the urine really is due to glomerular leak, which causes protein to end up in the tubules and then in the urine. So it's toxic to the kidney and the tubules. It's a really bad sign. You can see that even with a GFR of greater than 90, if you have proteinuria, which is defined as greater than 300 milligrams of albumin per gram of creatinine, and we'll talk about measurement of that later, that you're at high risk of progression, even if your GFR currently is fairly good. So when you see somebody talk about staging of chronic kidney disease, biggest thing is what is their GFR and do they or do they not have proteinuria? So different organs, same process. Patients with a history of stents, bypass surgery, CVAs, I often wonder whether their kidney has seen some sort of similar issue. Diabetic retinopathy and neuropathy. So if ophthalmology looks in their eyes and sees diabetic retinopathy, which is a damaging of the small blood vessels in the eyes, you can assume it's happening in the kidney too. This is very strongly proven in type 1 diabetics, but there's no reason to think it's not true in type 2 diabetics. And this can definitely save you a biopsy of the kidney if you can get an ophthalmologist to look in their eyes. And that really any embolic event. If you see somebody who's had a bypass surgery and their toes have, small little black areas, you can think about whether the kidney has had issues too. So chronic kidney disease is progressive. Once you have a GFR, usually it's under 40 or 30, you're on a train and you're headed to dialysis town. So the thing we want to do is slow the disease process, because the end of the line is dialysis, and dialysis patients do very, very poorly. So the two ways to do that is to slow down that hyperfiltration process we talked about and prevent any further loss of nephrons. If you do really well at these things, you can preserve kidney function fairly well. Typically, if patients do everything you ask of them and you get their blood pressure and diabetes under control, you only lose a point or two of GFR a year. But eventually every patient with CKD is a potential dialysis patient. The plan is to try and slow that down as much as possible. So the interventions for CKD, as you can imagine, are going to target diabetes and hypertension for the most part. The ACE and ARBs, these are going to inhibit the RAS system And this decreases the glomerular filtration pressure, which actually drops your GFR. So it sounds counterintuitive, but what you're doing is reducing the glomerular filtration pressure and slowing the CKD progression. Having somebody going from a GFR of 45 to 40 really isn't going to impact their clinical care. But if you can slow them down over the long term, you're really just slowing that train down. So this is particularly important if proteinuria is present, because lowering the pressure in the glomerulus causes less protein to leak out and less tubular damage and progression of CKD. SGLT2 inhibitors are fairly new. They excrete glucose in the urine, and I think of them as a CHF medication that has cardiac and renal benefits. So these are new, but they've been proven quite substantially to improve cardiac outcomes in renal disease. Main side effects are increased UTIs. We do see sometimes in the ICU, we've seen cases of lactic acidosis as well, which is kind of unclear how that works. Finerenone is still in trials, but it reduces inflammation in the kidney. It's for diabetic and CKD patients. And of course, aggressive management of diabetes hypertension is going to be key here. We talked about RAS inhibition. Second choice usually is a diuretic, some sort of thiazide diuretic, and then a vasodilator. Amlodipine has really been king lately because it requires no electrolyte monitoring, so that makes it a lot easier in the primary care world. And then, of course, the hardest thing is lifestyle changes. Probably the most important thing your patients can do is eat a plant-based diet. Even if their calorie intake doesn't change, there's something about a plant-based diet that is less acidic, causes less inflammation globally, but particularly in the kidneys. And if you can get patients to eat meat even just on weekends or once a week, it's really something that will help them. And then, like most diseases, exercise, weight loss, likely due to an improvement in those secondary things like hypertension and diabetes, is always helpful. So I'm talking about hypertension. There's a couple trials that have come out recently. The SPRINT study, which targeted lower MAPs, had less CAD events than patients with a normal MAP goal. There was no change in the progression of CKD, which some people were a little disappointed with, but really the cardiac events are what cause death in kidney patients. It's not actually the CKD that kills them. So the reduction in cardiac events was a big deal. The second study was all in African Americans, so they targeted blood pressures, systolic blood pressures of less than 120 versus the less than 140, and that actually did result in slower progression of CKD. They did have more side effects like hypotension, syncope, AKI, so I think people are kind of merging these two and talking about a systolic of less than 130 as a goal and a diastolic of less than 90. So that's kind of where my long-term hypertension goals lie. In the inpatient setting, it's a lot tougher and I'm a lot less aggressive, frankly. So we'll go over the common issues with CKD because these are the things you're going to have to manage in the hospital. Anemia, calcium phosphorus, metabolic acidosis, hyperkalemia, and fluid management. So kidney patients are often anemic, and this is usually because erythropoietin is made in the kidney. And it's made in the medulla, which is the most hypoxic part of the kidney. So when the oxygen concentration drops there, it stimulates production of erythropoietin, which causes your bone marrow to essentially make more red blood cells. Iron stores are often low as well. So what I do is check if the iron sats are less than 20% and the ferritin is less than 600, you can go ahead and load them with Venofer. Red blood cells are broken down more quickly in CKD, and inflammation and malnutrition are often factors as well. So calcium phosphorus imbalance in CKD and end-stage renal disease is one of our biggest challenges. Calcium tends to run low because phosphorus is poorly excreted by kidneys with CKD, so it binds to calcium and deposits all over the body. Decreased renal production of the useful form of vitamin D is also a problem, so I check those levels and usually a PTH to see if something needs supplementation. Long term, what we're trying to avoid is calciphylaxis. So this is why you see these renal patients on all these phos binders to help manage their calcium and phosphorus levels. It's generally a long-term game, and this is why their diet compliance is such a big portion of renal disease. So high phosphorus levels are really linked closely to poor patient compliance. So it's a hard thing to study and manage, but we know that keeping phosphorus low and calcium either low or low normal is the goal for the long term. The CKD patients frequently have metabolic acidosis. This is usually suspected when we see a low bicarb on a BMP, but I will say that you first need to get a blood gas to diagnose it. If you don't have a blood gas, you don't know if there's a respiratory component as well. So it's caused by an impaired ammonia production in the kidney, and this is usually not seen until the GFR is quite low, usually under 20. And remaining nephrons do increase their production, but they're unable to keep up, and this is just a keeping up with metabolism type situation. There's also decreased tubular reabsorption of bicarbonate, so just know that there's a couple different mechanisms why kidney patients run acidotic. And again, avoiding animal proteins, eating a vegetarian diet, increasing vegetables and fruits does help. Ultimately, you can supplement them with oral bicarb. They come in 650 milligram tabs. I usually start with that 3 times a day. I've had patients up to 1900 milligrams 3 times a day before we're eventually needing to think about starting dialysis. So hyperkalemia in CKD patients usually is intake, output, and shifting. So we'll take these one at a time. Intake, you can have them follow a low potassium diet. If they're on a tube feeding and their potassium is in the 5s, please switch them to a renal tube feed. Their output is going to be reduced in kidney failure because of the excretion of potassium is lower. The GI tract does try and pick up some of this excretion, and it's usually responsible for about 5% of potassium excretion, but it can usually double that to somewhere around 10%. K-oxalate and patiromer are 2 agents that you can use to artificially remove potassium via the gut, although I will say they are not generally good agents for very sick patients, especially if you're suspecting any sort of GI ischemia. And then shifting. If they're hyperglycemic, you can fix that, and it usually will make your number look quite a bit better. If they're acidotic, and you can give them bicarb or change their vent settings to get more CO2 out, those sort of things will really help your potassium level as well. The fluid management in CKD can be a real challenge, especially because a lot of these patients with hypertension and diabetes will also have heart failure or other sort of issues like that. Fluid restriction is a very unpopular but very important part of these patients' management. So we all lose about half a liter of insensible losses a day. So I try and tell patients that 1 liter is about all they need of fluid. So if possible, put them on a 1 liter fluid restriction. It's going to make your output goals a lot easier if your intake is reasonable. And then loop diuretics are probably our most effective way of getting fluid out. Unfortunately, this is associated with a more rapid progression to end-stage renal disease, although there's a lot of selection bias here because the people you're going to give loop diuretics to are the ones with more problems, more poor adherence, like we talked about with the calcium phosphorus issues. And so it's no surprise that these patients end up doing more poorly long term. So one of the biggest questions I get is when a patient has an AKI in the hospital or an AKI on top of CKD, do they need to see nephrology? So these are my general rules. Once the GFR is less than 30, they should be seeing a nephrologist at least once a year, something like that. If it's less than 20, nephrology will be thinking about dialysis, getting them access, sending them to Kidney Smart class where we talk about the different forms of dialysis. And dialysis for end-stage renal disease typically starts around a GFR of 10 to 12, depending on their symptoms. The big things I look for are loss of appetite, weight loss, if they have any sort of forgetfulness, neurological problems. These are things in the outpatient setting that really push you towards starting dialysis. I will pause here and just say that the highest mortality time period in kidney patients is the first 6 months of dialysis with a catheter. So if you can avoid that and get a fistula in ahead of time, it saves lives. So the planning regarding access is really something important in these patients. So here's some further reading on things described in this slide, and we'll be ready to move on to acute kidney injuries next, which is more of the inpatient focus.